I'd like to welcome everyone today to the Vasculitis Foundation webinar. I'm Kathy Olewski, the host for the Vasculitis Foundation Educational Webinar Series. I'm also a patient living with MPA vasculitis. Today's webinar is actually a quiz about vasculitis. This is a new effort, and we hope it's fun and engaging and educational at the same time. We hope you'll learn a good bit more about vasculitis today. We're grateful to have Dr. Kevin Byram with us today to educate us and answer some questions. These webinars are part of the Vasculitis Foundation's commitment to patient education, and we would like to thank our sponsors, AstraZeneca, Amgen, and Novartis, for supporting these webinars. Let me introduce our guest. Dr. Kevin Byram is the director of the Vanderbilt Vasculitis Clinic. He's an associate professor of medicine in the Division of Rheumatology at Vanderbilt University School of Medicine in Nashville, Tennessee. And Dr. Byram is also the 2024 board president for the Vasculitis Foundation. Welcome, Dr. Byram.
Thanks for having me.
And at this point, I'd also like to ask if you have any disclosures.
No disclosures.
Okay, well then the next excuse me, the next step is I'm going to share my screen so we have a great quiz that we would like to share with everybody today and see if we can go over a few things about vasculitis. Let me put it in the proper view here. There we are. And so I would like to get started today by saying this is our vasculitis quiz. And the first slide that we have is about autoimmune disorders. True or false, is vasculitis an autoimmune disease? And the answer is true. And I was just going to say, I hear about autoimmune diseases all the time. Are there a lot of types of autoimmune disease, Dr. Byram?
Yeah, certainly there are. That's the day-to-day life of a rheumatologist, and other specialists are sorting through these various diagnoses. So I think that's one learning point from this question, is to think about vasculitis as a type of autoimmune disease, with autoimmune disease being kind of an umbrella. There are other autoimmune diseases like lupus, rheumatoid arthritis, ankylosing spondylitis, these sorts of things. And there's different patterns for each, and vasculitis fits under that umbrella.
Interesting. Okay, well, we'll move to the next slide, which is, if I can move it, there we go. Rudolf Virchow first described vasculitis in what year? Was it 1979, 1958, 1847, or 1932? And the answer is 1847. Wow, that was so long ago. I'm very surprised to hear that.
Yeah, this is an oft-repeated case report that gets put out there. It was probably either polyarteritis nodosa or microscopic polyangiitis, but it was kind of in that realm of diseases. It's probably worth noting there are other likely vasculitis reports that probably predate this, particularly from the Middle Eastern literature, but this was one of the first, at least in Western medicine, that we look back upon and definitively say that was vasculitis.
Interesting. I never would have thought 1847. And the next one is, there are how many types of vasculitis? 3, 5, 10, or 15 plus? And the answer is 15 plus. Boy, I've heard a lot of comments about this. I've heard 15, 18, 23. Is there a consensus on this?
Probably not. The last time that we actually have consensus on the different types of vasculitis was over a decade ago in Chapel Hill. The 2012 classifications and consensus criteria get held up. And so, yeah, there's a lot of kind of mild controversy about this, and it gets philosophical and semantic pretty quickly. There are the three kind of types: large, medium, and small vessel, but there are some types that don't fit neatly into those, like Behçet's disease is a variable vessel. And there really are probably countless different types related to secondary causes like medications, or infections and things like that. So I think 15 plus is a good answer here. There's a lot of different types, And I think, in some ways we're a community and we want to kind of open our arms to all that could be possibly classified as vasculitis. So I think having a broad definition of the types is probably a good way to go.
Well, it certainly sounds like it. I have a thought as a patient. Could a type of something that's classified as vasculitis right now, could it be removed and no longer be a vasculitis?
Oh, that's interesting. Probably not in the way our current like to get diagnosed as a vasculitis, there usually has to be defined evidence of inflammation of a blood vessel. And so I think that, the classifications will likely stay. What I will say is that with um, things can be reclassified and rediscovered. We have two good examples of that recently would be something like the Vexus syndrome that was recently described in the last 3 or 4 years. Some of these patients have defined vasculitis like giant cell arteritis or other types of skin or lung vasculitis, but it's been discovered to be secondary to another cause. IgG4 related disease is another one of those. So there's all kinds of diseases that are kind of being rediscovered and reclassified. But I think once in the club, you're always in the club.
Okay. Well, that's a good way to put it for me. And then the next slide is vasculitis is classified by the predominant size of involved blood vessels, large vessel, medium vessel, and small vessel. Which of the following types of vasculitis are classified as large vessel? Aortitis, Kawasaki, granulomatosis with polyangiitis, polymyalgia rheumatica, polyarteritis nodosa, Takayasu arteritis. I said all of those words.
Yeah, you did well.
And the answers are aortitis, Takayasu arteritis, and PMR. And I just thought maybe we would clarify a little bit about the difference between the various types of arteries that are attributed to them. And I actually have a slide that might help you clarify for us, if that's okay.
Yeah, sure. Yeah, this is great. The two classic large vessel vasculitis syndromes are known as Takayasu's arteritis and giant cell arteritis. I like this question. I mean, it's confusing in some ways, but it's a great question because it gets at the different terms we use for kind of similar diseases. So in this question, aortitis was referenced, and that is by definition inflammation of the aorta, which is the biggest blood vessel in our bodies. And that can happen in both Takayasu's arteritis and giant cell arteritis. And then I like this question too because it gets at this polymyalgia rheumatica, which is been increasingly, and for a long time, it's been associated with giant cell arteritis. It can be a harbinger of that, up to, depends on who you ask, but maybe a third of patients with polymyalgia rheumatica will develop giant cell arteritis. So I really like that question because it gets at kind of different names for different things that we have.
Okay, well, great. I think it's always confusing to patients to learn that they have medium, large, or small vessel, but that certainly does help us understand it. And moving along, the next one is, which of the following diseases are not forms of vasculitis? Systemic lupus, Cogan syndrome, polymyalgia rheumatica, arthritis, Sjogren's syndrome, or Behçet syndrome? And the answers are the systemic lupus, okay, we'll just say lupus, arthritis, and Sjogren's syndrome. And I was just going to say also as a patient that I hear there's some confusion about arthritis and vasculitis and that they're different things, but you can have both. But arthritis is not a form of vasculitis. Did you want to comment a little bit on why people get these things confused or how we can clear it up?
Sure, yeah. Arthritis, as stated there, is quite a general term and can mean anything from wear and tear, age-related osteoarthritis, all the way to things like inflammatory arthritis. Maybe the most common one people hear of is rheumatoid arthritis or even gout. But what we do know is that diseases like GPA, Behçet's, Cogan's, these things can have an inflammatory arthritis that comes along with them. but in general, not all arthritis is a vasculitis. So I guess restated, vasculitis can have arthritis, but not all arthritis is vasculitis. I like this question too because it gets at a couple of lesser known types of vasculitis, Behçet syndrome, of course, and then Cogan syndrome, which itself can be associated with aortitis, going back to the question beforehand. So this is another good question. I think the last comment here is that, our patients with rheumatoid arthritis and lupus and Sjogren's can all have vasculitis secondary to their underlying disease, but not all patients with lupus, arthritis, and Sjogren's have vasculitis. So vasculitis can touch a lot of these patients, but it's not in every case.
Understood. Okay, and moving to the next one, Antineutrophil cytoplasmic antibody, or ANCA, is a blood test commonly elevated in patients and is found in which types of vasculitis? Granulomatosis with polyangiitis, microscopic polyangiitis, cryoglobulemic vasculitis, eosinophilic granulomatosis with polyangiitis, polyarteritis nodosa, or giant cell arteritis. And the answers are granulomatosis with polyangiitis, microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis. And so in layperson terms, what's the difference between ANCA and ANA, and how relevant is that to vasculitis? Because I think this is also a very confusing thing for a lot of us.
Yeah, certainly so. So you've highlighted the three prototype small vessel vasculitis syndromes, and these are associated with the ANCA blood test. Perhaps, most patients, when they're first going to their doctor to be evaluated, they have a big, if you probably remember it, you had a lot of blood drawn, and commonly in that blood panel, the ANCA test is there and the ANA test is there. These are all these get at trying to find autoantibodies, so antibodies against something you're not really supposed to react against. ANCA are more rare and therefore more specific for the disease that they associate with. ANAs, it's not uncommon to find ANAs in up to maybe even 20 or 25% of the general population. But the ANA test is typically held up as the lupus test. It has a group of specific antibodies that can be associated with lupus. So really, it's kind of the lupus, Sjogren's, scleroderma test, and then this ANCA test is for these three diseases.
Okay, and I have two more questions about
Sure.
this. One is, I hear patients all the time in the social media groups talking about how their ANCA titer is positive, but their doctor is still saying that they are in remission. And then the other one is ANCA found in any other autoimmune diseases besides vasculitis?
These are two really, really good questions. The first question getting at being in remission but still having an elevated ANCA, that we do see that sometimes. I guess zooming out, when we look at large groups of patients, like hundreds of patients, there is this tendency for positive ANCAs or increasing ANCA levels to be associated with worsening disease or flares of disease. But on the individual level, that breaks down because in those studies, there are people that have really high levels that never have a flare, that remain in remission for years and years. And then there are some people that flare with normal levels of ANCA. And so you just have to maintain regular follow-up with your doctor. It comes all down to the clinical syndrome. We don't want to chase just numbers. We can actually overtreat people in those cases and give them side effects and things. Getting at the second question, you're getting at what other diseases can be associated with an ANCA. And we refer to that as specificity. It generally has a high specificity. I mean, vasculitis is certainly the most common thing it's associated with. We do find some ANCA that is associated with nothing. And those patients just need to be watched for development of symptoms of potentially a vasculitis. There are some other diseases that can be associated. Infection of the heart, so endocarditis is one of those, infections of other types. And then it can be associated with some medications sometimes as well. Inflammatory bowel disease is another where patients can have atypical ANCA results. So there is a list. It's an important when you do get an abnormal ANCA test, just to follow up with your doctor and walk through that list of things and see if any of the symptoms go with that, and if any further evaluation needs to be done.
Okay, well, that is definitely a confusing topic for a lot of people, so I appreciate that clarification.
Sure.
And moving on to the next one, true or false? Glucocorticoids such as prednisone are often the first line of treatment for vasculitis to reduce inflammation. Glucocorticoids not only reduce inflammation, but they are also considered immunosuppressives. So we're seeing, is that a true or false statement? And it is true. And I do think that some patients realize that prednisone is also considered an immunosuppressant, but I always thought maybe it was just given to reduce inflammation. It does have a dual role, doesn't it?
It does, yes. Many times at the beginning of a diagnosis, right after a diagnosis is made, sometimes before diagnosis, but certainly after, that's when the patient might be on the highest dose of glucocorticoids that they might ever be on. And certainly it is enough to suppress an immune system and increase the risk of infection. So, good communication with your doctor about any symptoms that might represent an infection are important.
And is it a basic treatment to put glucocorticoids in to start to reduce the inflammation? Because I feel like that's the beginning of every time I've had a flare. That was one of the first things that was done, that they needed to suppress my immune system. And I always just thought of it as, yes, please save my kidneys.
Right. This glucocorticoids are they're the drug that work the quickest of all of the drugs that we have in our at our disposal. So really, steroids, glucocorticoids will tend to work within hours to days, but other medications, everything from the methotrexate, azathioprine, mycophenolate, rituximab, et cetera. All these things take some time to really have the effect on the immune system that we want, on the order of maybe weeks to months. So that's why glucocorticoids are the first line, is because they're the quickest.
Okay, well, we love them and hate them, so we
Right.
understand.
We do too.
All right, and moving to the next one, let's see, here we are. Which of the following statements are true about vasculitis? So we're looking for things that are true here. It's usually possible to know if someone has vasculitis from their appearance. There is a cure for vasculitis. Fatigue is not a common symptom with vasculitis. Vasculitis mostly affects patients over the age of 65. None of these answers are true. They are all incorrect. Or vasculitis is a blood disorder. So now we see what the answer is. None of these answers are true. They are all incorrect. Probably misconceptions is more appropriate about vasculitis. And I have to say, I've heard all of them. And as a patient, I think one of the biggest ones is, oh, you look fine. And I don't think people understand that what's going on internally is not in us, in our disease, and vasculitis is not often reflected on the outside. And then the other one is, when I'm in remission, people think it's a cure, especially which I am, lucky enough to be in long-term remission. And that's another misconception, that I have to be aware of this my entire life.
Right. Yeah, I've heard all of these on the provider side as well. Certainly vasculitis can affect anybody. We have pediatric cases all the way to the most elderly of patients. Fatigue is probably, I would argue, it might be the most common symptom with vasculitis. We hear about this a lot. And then you hit on a couple of really big ones there. We hear from our patients that they get frustrated at maybe their colleagues or their friends not understanding their diagnosis. And then the cure, we hope for a cure. Sometimes we can get people into really deep remissions, and we do have a small subset of patients that we can get off of medicine. But really, those patients still are, I like your phrasing of a durable long-term remission, because those patients still need to be monitored in case, signs and symptoms come back. So I think this is it's a tricky question, but it's a good question.
Yeah, and when I was speaking about long-term remission, I had long-term remission, I think it was like 9 years off treatment, and then I had a flare.
Right.
I mean, and then I was back in treatment, and these things happen. Mine was precipitated by something else that happened to me, and we think it kind of pushed me into a flare. But one of the other things that's confusing on this slide is vasculitis is a blood disorder. I mean, I know it is not technically a blood disorder, but there was a celebrity, and I think an interview that said that it was a blood disorder that he had when he actually had vasculitis. So that's just another one that's a little confusing for patients.
Yeah, I think it's certainly a blood vessel disorder. So I'm not sure if there was um, if something was misconstrued. But I also, in these autoantibody driven diseases, there's something wrong with the blood in some sense. But I don't think that's a good conceptualization of this. It's not like a blood cancer or something like that. So
Blood vessel disorder, that sounds more appropriate. Just
sure.
missing one word. No problem at all. Okay, and moving on to the next slide, which of the following statements are not true about vasculitis? So this is kind of a reverse of the previous one. Vasculitis is a serious life-changing illness. Vasculitis affects the emotional health of patients. Reducing steroid usage is a major goal in vasculitis research. Most forms of vasculitis are chronic, with periods of relapse and remission. Potential bone loss, osteoporosis, can occur with steroids. All of these answers are true. Well, the actual answer is all of these statements are true. And I think this is just to play on the question before. This is what the realities are for patients, and especially the emotional impact and the relapse and remission. Any thoughts on that, Dr. Byram?
Yeah, this is another great question. I couldn't agree more with really all these statements. We worry about the side effects of steroids, and so the two of these answers hit on that. And then your story highlights that these diseases are chronic and there are periods of remission, but they do have the potential for relapse. The emotional health, I think we're all appreciating that more and more, and hopefully providers are attuned to that. The medical side of this doesn't happen in a vacuum. And then they are certainly serious and life-changing.
Okay, and I did want to thank you for taking your time to educate us, Dr. Byram. And as a patient, I just want to say, for those of you that are watching, this is a great resource to share with your friends and families. The last two questions in particular are things that come up for me as a patient all the time. And I think if you could show your friends and family something that has been verified with our medical personnel, Dr. Byram here with us today, then they are more likely to understand and support you in your journey of vasculitis. I also want to say to the patients, did you ever wonder how you could have an impact on important vasculitis research? The answer is that you could join the Vasculitis Patient Powered Network, the VPPRN. I'm actually a patient champion for the VPPRN, and I encourage other patients to join the VPPRN and to complete their biannual forms. They're actually very simple forms. They take about 10 minutes twice a year to complete. I just can't tell you everything you need to know about the VPPRN, so I would encourage you to learn more by visiting their website, which is the vpprn.org. And what I can tell you is that it's a global patient registry. Patient data, that means your data, drives research in vasculitis. And by providing researchers with information about you and your experience, that's the key for advancing our knowledge of vasculitis. We also would like to thank the Vasculitis Foundation for hosting these medical webinars, and our sponsors, Amgen, AstraZeneca, and Novartis. And of course, Dr. Byram, thank you so much for your input today.
Again, thank you for having me.